Hey guys, Don here. Welcome to the Million Dollar Minute. Going to go over kind of what helps get to the $1 million mark and beyond. I am probably posting this New Year's, but it's New Year's Eve when I'm recording it. Just my last day of patience here. Want to share a couple of things. First of all, I want to thank you all for listening to this podcast. There are a number of people that I get feedback. Certainly, if you like it, let me know. Shoot me an email down at Podiatry Practice Mastery. That's the least you could do if you're getting benefit. And tell me how it's kind of benefited your practice. I would really like to know, like, what are some of the best pearls. Before I go through the day, it was a half day, but I want to go through X-rays. I think one of the things that sets, good practices or the best practices apart are really having a consistent method of staff knowing when to get X-rays. What we train our staff basically is they do X-rays for everything. It has to be a profit center, and it has to be used. So what that means is any patient that comes in with foot pain or foot abnormality, they get to get an X-ray even before we see them. Now, a lot of people, they'll say, "Oh, I don't want to overdo X-rays. I don't want to get audited on X-rays." I've never had an issue with doing an X-ray or an ABI or an ultrasound on patients. And so it's good medicine, and it's something that's low-hanging fruit that I think a lot of the practices, I get doctors or patients that come in and say, "Oh, my doctor never got an X-ray," or I think the X-ray was at the hospital. So if you have digital X-rays, like every patient's getting an X-ray. If they doubt, if the patients or the staff are uncertain, have them get an X-ray. Okay, I get a little bit angry if they don't, only because it takes my time. That I see the patient, have them get the X-ray, and then I have to go see him again. If the patient says no, or they just had one somewhere else, I ask them to check to make sure it was weight-bearing. Most places they don't do weight-bearing X-rays, and most people don't have a copy of them, and I don't really have access to getting those. So I always get new X-rays. Never been a problem for that. I do them before I see them, just because I can review them with my scribe before, and then a lot of times I will just tell them what was on the X-ray, but sometimes I'll show the patient. And a good tip about X-rays is I have the patients take a picture with their cell phone, because a lot of them want to kind of like remember what's going on. So I've never been a problem. That was my kind of my rant on X-rays. I am starting to use softwave in our office. So just so you know, at one office we have radial and focused shockwave, and in the other office we have radial and softwave. Now, for some reason they let us use one here. I think maybe because my partner is going to maybe do some lecturing for them. So I had to make a new template. So I have two templates. So I have three templates for shockwave for my procedure. One's a radial one. One is a focused combo, which would be radial and focused, and the softwave is called unfocused. So I have an unfocused combo. So I have three of these. If you need any of my templates, you can go to podiatrypracticemastery.com/EMR, and all of my templates are in there. I don't know if this unfocused one isn't just because I made it, but those are all my templates if you want to use any of those for your EMRs. Okay, the new one is 8 hertz, 12 is the energy, and 1500 pulses. So it's a little bit less pulses, and 2000 is normally what I do for radial and for focused, but unfocused I'm doing 1500. So that's that. Let's talk about the day. A couple of cancellations from patients. I always like to let people know about that. So I had 14 scheduled. I think 12 showed up. The patient, I guess that would be the most valuable patient, was a patient that came in with the Achilles tendonitis and a heel spur. And I started Achilles visit number 1, which would then be like a night splint, foam rolling, morning stretch, meloxicam, and then they'll be back in 3 weeks and possibly an ultrasound with shockwave. And I kind of prepped her for that, the shockwave, and I sent her some information on shockwave and a video on Achilles, and then I'm also trying this thing called Next Step, which is this remote patient monitoring thing for it. We'll see if that works. Okay, for patients. Okay, other patient that came in. This was a patient. He had kind of some pain, but really what happened, and he was part of a practice that was recently took over by a son-in-law and a daughter, where the father was a practice for 40 years, kind of gave them the parent practice, and he came over here for us. So he just wasn't pleased. He felt like, he actually said the words were, the other doctor didn't really seem interested in me. And I think a lot of times when doctors are coming out of our residencies today, they are all surgically trained, and so what's not interesting is routine care, right? So If you don't have a way to make it profitable, you might not take interest in that, but a lot of these practices were built up on that, and you can get a lot of other conditions based on that. So we've kind of tried to make it profitable. What we found is that doing a block of time, so I do Friday mornings until noon, I double book every 10 minutes. So basically patients every 10 minutes, and I have a medical assistant or a nail tech that helps me. She's starting. She's just still doing the training right now. That's how we've made it profitable. So this gentleman, he'll go into that schedule, or with me or one of the other doctors. But I did get a level 3 visit, x-rays, and I did routine care. So going back, and as I started out talking about x-rays, well, a lot of people wouldn't have gotten it, the x-rays. So he had bunions, Taylor's bunions, foot deformity. My staff knew enough to get that. Okay, that would be a reason to getting an x-ray. Another patient came in with a foreign body today, got an x-ray. Okay, so some people don't do that for foreign bodies. So just to kind of give you some examples of reasons to do x-rays. So whenever in doubt, just do an x-ray. This was another patient that just had foot swelling, got an x-ray, level 3 visit. Another patient came in for EPAT number 2. This is where I did the radial and unfocused shockwave. I'm getting used to it, a little bit easier to do. It's got a little bright light that comes with it. It's kind of a cool thing. Another little boy with flat feet. Spent a lot of time with the mother, going over flat feet, did my presentation, got x-rays, gave him information. He's young, like 13, so they didn't want to do custom orthotics because they were going to grow out. He had some power steps. He hadn't worked into them. I taught them how to work in, but I really said long-term he's going to need some custom orthotics, and I talked to them about that. Another patient came in for an ulcer visit and debrided it. This is something else with ulcers. Like, all ulcers are getting debridements. I don't know if some people are just maybe doing office visit for ulcers, but ulcers, I'm always debriding them. Occasionally I'm doing office visit, but a lot of times not. Another patient came in for a hammer toe. Had painful. I did an exostectomy on the second toe on the medial side a few months back for an exostosis, but she still had pain from the hammer toe, and she only found like certain shoes were comfortable. But it's because she also had a hammer toe with arthritis, so I did a Crest pad, and all of her pain went away. So she was super happy. Also did a patient plantar fasciitis visit number 1, which would be x-rays, foam rolling, night splint, morning stretch, 3-week follow-up with ultrasound, level 4 visit because of the meloxicam. Another patient, that foreign body I talked about, did x-rays, did ultrasound, did the foreign body removal, and I'll see her back in 2 weeks. And I gave her an antibiotic as well, so level 4 visit because of the antibiotic, just in case, because it's the holiday season. Also, this is a patient with unfocused shockwave, and then a matrix follow-up at 3 weeks, which is doing much better. And then finally, there's another patient. This is a patient that had kind of like a wavy toenail. Both big toenails are wavy, been that way for 15 years, and she's only like 25. So if you have any ideas on how to treat these wavy toenails, like where it's a nail on top of a nail, usually I'll just grind them down and do Cariflex to make it look pretty, but I would love to know if anyone has any ideas. I told her about shoes. She has a little bit of a bunion that could be contributing to it. Could be the kind of pressure, but I've thought about avulsing it and putting on an Onifix in 3 months to see if it'll kind of stabilize the nail and grow out normal. So if anyone has any good nail issues, like nail ways of treating wavy toenails, like both big toenails are like wavy, like one growing on top of another, I'd love to hear that. Send me an email down at podiatrypracticemastery.com, and I will share it with everyone else what I learn. Okay? Once again, have a good New Year. Thank you all for being part and listening, and please share this with others. If you found this beneficial, share it with some of your other colleagues so we can get more readers and listeners and things like that. And if you want to learn more, go to Podiatry Practice Mastery. A lot of freebie stuff right on that website.